Welcome to the Deep Dive, gearing you up for the FRCS Plast. We're diving into fat grafting today.
A popular procedure, for sure,
Yeah,
but one that's got a lot of nuances the exam really loves.
right. So it's more than just moving fat around, isn't it?
Absolutely. It's adipose tissue transfer,
Yeah.
and understanding why that matters is key, especially for long-term results.
Okay, let's break it down. What's in these grafts exactly? What are we actually transplanting?
Well, you've got your mature fat cells, the adipocytes, of course,
Mhm.
but also, and this is crucial, pre-adipocytes. Think stem cells.
Right, stem cells.
Yep. And those are tougher. They handle the lack of blood flow better than mature fat cells. Plus, get this, they can turn into even more fat cells after they're transplanted.
So graft survival isn't just about moving fat, it's about moving these cells with regenerative potential.
Exactly. The cell survival theory, as it's called. Basically, how well those adipocytes live directly impacts how long the graft lasts.
Makes sense. It's a living thing we're transplanting, not just filler.
Right. And that's something the exam often focuses on.
Let's talk about where this technique comes into play. Where is it used?
Oh, tons of places. For the breast, you see it used for all sorts of things. Contour irregularities after reconstruction or augmentation. Congenital deformities like micro, tuberous breast, Poland syndrome, post-mastectomy deformities, even for improving radiation-damaged skin.
Radiation-damaged skin. Can you expand on that? How does fat grafting help there?
It seems to have this regenerative effect. Less collagen buildup, less epidermal thickening. It even improves that hyperpigmentation you often see.
Interesting. So it's almost like it's reversing some of that damage.
In a way, yeah. And the exam might ask about those specific benefits.
Beyond the breast, where else is fat grafting used a lot?
The face is another big one. We see it for lipoatrophy, post-traumatic deformities, augmentation of the lips, the malar region, periorbital rejuvenation, nasolabial fold augmentation, even those depressed acne scars.
That's quite a list. Anything less common we should be aware of?
Oh, definitely. Penile enlargement, burn scar contractures. You see it for radiation damage, congenital constriction bands, all sorts of things. The key is understanding those core principles,
Right.
and then you can apply that to different scenarios, which is honestly a classic FRCS approach.
Makes sense.
Yeah.
Okay, before we get into the actual technique, let's talk patient selection. What makes a good candidate for fat grafting?
Managing expectations. That's the biggest thing. This isn't a magic bullet, right?
Yeah.
You need to make sure patients understand they might need multiple procedures to get where they want to be.
What about factors that affect the graft itself? How well it survives?
There's a lot there. Extrinsic factors like smoking, not eating right, certain medications like sympathomimetic drugs, and conditions like obesity, diabetes, COPD, those all hurt graft survival.
So getting those under control beforehand is key. What makes fat grafting so appealing in the first place, though? Why choose it?
Well, it's safe. Biocompatible, non-immunogenic, you're using the patient's own tissue. No need for those synthetic fillers. And it's readily available. Abundant, relatively inexpensive. Plus, you can often improve the contour at the donor site while you're at it. Minimal morbidity.
Okay, so a lot of pluses. What are the downside then?
Unpredictability of long-term results. That's the main thing. You never know how much of that graft is going to stick around. And the technique itself, it's very operator dependent. You really got to master it to get consistent outcomes.
So a lot of room for skill to come into play.
For sure.
All right, let's move on to the procedure itself. Starting with the fat harvest, what are the guiding principles there?
Atraumatic technique. That's the golden rule. You got to minimize trauma during every step. Harvesting, handling, transplanting. The less trauma, the more volume you're going to keep long-term.
How do you ensure you're harvesting atraumatically? What's the method?
The Coleman technique is pretty popular. It's manual. You use a small incision, a large bore cannula, and very gentle negative pressure.
Okay. Can you walk us through the steps?
Sure. You start with a small incision, about 5 millimeters, strategically placed, of course. Then you infiltrate the area with a wetting solution.
What's in that wetting solution, and what's it for?
It depends. It's either lidocaine with epinephrine if you're doing local anesthesia, or just Epio in lactated ringers if they're under general. And the purpose is to reduce bleeding, minimizes the blood that gets in the harvested tissue, which is really important for graft survival.
Right, so less blood, healthier graft.
Exactly. And you gotta wait like 7 to 10 minutes after infiltration for the epi to really kick in.
Good to know. What's the next step?
So then you use a special harvesting cannula, usually about 3 millimeters, with a 17-gauge lumen, blunt tip. This is hooked up to a 10 cc syringe. And you apply gentle back pressure on the plunger to create that light negative pressure we were talking about.
Okay, so the setup is important. How is the fat actually harvested then?
With the cannula in place, you make these long, even strokes, radial strokes, through the subcutaneous tissue. You're smoothly advancing and retracting the cannula.
I see, so it's a very controlled motion.
Exactly. Once the syringe is full, you remove the cannula, cap it, prevent any leakage.
All right, so precision is key. You mentioned the Coleman technique is popular. Are there other ways to harvest fat?
Yeah, some surgeons use suction-assisted harvesting, especially if they need larger volumes.
What are the trade-offs there?
It's definitely faster for large volumes, but you tend to get a bigger oil layer after processing, which means you've got more fat cell rupture.
Ah, so efficiency versus cell viability.
Yeah, exactly. That's often the choice you're making.
Does where you harvest the fat from matter? Does the donor site affect those adipocytes?
Interesting question. Studies haven't shown a big difference in viability based on the donor site, so it really comes down to practicality. Access, patient positioning, whether you need to contour the donor site, even patient preference sometimes.
Are there areas you want to avoid
Mm.
or be extra careful with?
Absolutely. There are zones of adherence. That's where the skin is really stuck to the tissues underneath, like the distal iliotibial tract, the gluteal crease, the lateral gluteal depression, the middle medial thigh, and the distal posterior thigh.
And why are those areas tricky?
Well, if you harvest too aggressively there, you can get contour irregularities.
So donor site selection is more about practicality and aesthetics than about those cells themselves.
Exactly.
All right. Let's move on to processing the fat. Why do we need to refine the harvested tissue?
Well, the goal is to get pure fat for grafting. You want to get rid of things like blood, fluids, damaged cells. All that stuff can hurt graft survival and lead to complications.
Right, so we're cleaning it up, basically.
Yeah, in a way. What are the main methods for doing that, you ask?
I do.
Centrifugation, washing, and sedimentation. They all have their pluses and minuses.
Let's start with centrifugation. How does that work?
You take those filled syringes, put them in a centrifuge, and spin them. Forces the components to separate by density.
Makes sense. What's the sweet spot for that? Speed and time.
Usually 1,500 to 3,000 RPM for 2 to 3 minutes, but some people have good results with lower G-force centrifugation, like 15 to 20 G.
So some variation is okay.
Yeah. The key is finding that balance, Good separation without damaging the cells. Over centrifugation, that's bad news.
What happens if you centrifuge for too long?
After those 2-3 minutes, you're not really getting any more separation, and the longer you spin, the more you actually start killing those fat cells.
So precision matters.
Yeah.
What does the fat look like after you've centrifuged it?
You get 3 layers. Top layer's oil from ruptured cells. Middle layer, that's your pure fat, the good stuff. And the bottom layer is a mix of blood, water, whatever local anesthetic you use.
Okay, so layers based on density. How do you handle them?
You get rid of the oil, obviously, and then you drain that bottom layer, the aqueous layer, leaving you with the purified fat in the middle.
Makes sense. You mentioned washing. How's that different?
So with washing, you're mixing the fat with a solution. Saline, 5% glucose, lactated ringers, sterile water.
Basically rinsing it.
Yeah. It helps remove debris, inflammatory mediators. Mix it up, let it settle, then remove that top layer, the supernatant. Repeat until it's clear.
Is that better than centrifugation?
Not really. Both have similar results. It often comes down to what the surgeon prefers.
Okay, so surgeon preference. What about sedimentation then? How does that one work?
Sedimentation is the simplest, honestly. You just let the fat settle in syringe using gravity. Heavier stuff sinks, pure fat rises to the top.
And how long does that take?
Can take up to an hour, so it's much slower than those other two.
So again, a trade-off.
Yeah.
Less trauma, but less efficiency.
Exactly. Some surgeons combine it with decanting, pouring off that top layer of fat to further refine it.
Clever. Any other processing techniques out there?
Yeah, there's one called cotton gauze rolling. You spread the fat out on this non-stick absorbent gauze, roll it, knead it. That separates the oil and aqueous layers while keeping that stromal component we talked about.
Sounds pretty hands-on.
It is. But the key with all of these is understanding the principles behind them. Then you can choose what works best for you and the specific case.
Makes sense. All right, we've got our purified fat. Let's talk about injection. What are the key things to keep in mind during that step?
A traumatic technique again. And you want to distribute that fat evenly. Small aliquots. That maximizes contact with the surrounding tissue and helps with new blood vessel growth.
Right, because we need those blood vessels for survival.
Exactly.
What about the cannulas? What kind are used for injection?
Typically shorter and thinner than the harvesting cannula, 9 centimeter cannula, usually with a 17-gauge lumen. Then that's attached to a 1 or 3 cc syringe. Depends on where you're injecting.
Okay, so size matters. What about the tip of the cannula?
Blunt or sharp? Those sharp ones, sometimes called pickle forks, they're good for breaking up fibrous tissue.
Interesting. So the type of tip can be important too. Let's walk through the actual injection technique now.
One approach that's pretty popular is called structural fat placement. The idea is you're placing the fat very precisely to create this supportive framework.
Okay, how's that done?
You transfer that purified fat from those 10 cc syringes into smaller ones, 1 or 3 cc. Make small incisions for good access to the area. Then you advance a cannula and inject the fat in tiny amounts, like 0.1 cc aliquots, as you withdraw the cannula.
Why such small aliquots?
Surface area. The smaller the aliquots, the more contact the fat cells have with the surrounding tissue. That means more nutrients, better survival.
It's all about maximizing contact for those cells.
Exactly. And you want to distribute the fat in a cross-hatched pattern. Make sure it's even and prevents clumping.
What about preventing irregularities? Any tips there?
You can use your fingers to smooth things out a bit, but gotta be gentle. You don't want to damage those fat cells.
So gentle manipulation is key. What if you're injecting a large volume of fat? Does that change the approach?
Yeah, if you're doing like 200 to 300 cc's per site, you might use larger syringes, 10 cc, or even 60, just for efficiency.
And the injection technique itself?
Still multiplanar, radially oriented passes, but you might deposit slightly larger aliquots.
Makes sense. You'd need to adjust for the volume.
Right. And studies show that larger aliquots actually do better when injected intramuscularly compared to subcutaneously.
So where you inject and the size of the aliquot both can affect survival.
Absolutely.
Yeah.
Now, let's talk about what actually determines whether a grafted fat cell survives.
Okay. What are those determining factors?
Initially, the graft lives off the surrounding tissue. It absorbs nutrients from the surrounding fluid. That's called plasmatic imbibition. Happens before new blood vessels grow in.
So a temporary support system.
Exactly. And this is why the size of the grafts matter. If they're too big, those cells in the center won't get enough nutrients.
They starve, basically.
Yeah, and they die. That's necrosis.
What's the ideal size, then, to make sure most of the graft survives?
Studies suggest that an aliquot should be about 3 millimeters in diameter. That seems to be the sweet spot.
So it's a balancing act. Enough fat for volume, but small enough for those cells to survive.
Exactly.
Are there ways to enhance that survival, aside from size?
Yeah, there's been a lot of interest in using platelet-rich plasma, PRP.
PRP. We hear about that everywhere.
It's got all these growth factors, other good stuff, seems to stimulate cell growth, helps with new blood vessel formation, might even reduce inflammation and those oil cysts that can form.
So it's like a little boost for the graft.
Exactly.
All right, last thing on this part. What about storing the fat? Any considerations there?
Oh, big time. Fat cells are fragile. They start degrading quickly. So ideally, you want to transplant it ASAP after processing.
What's the time limit, realistically?
Studies show they start to go downhill after about 4 hours at room temp.
So time is of the essence. What about freezing it for later use?
You can, but cryopreservation can really hurt the viability of the tissue. There are controlled rate freezing techniques that help, but it's still not ideal.
What about adding those cryopreservative agents?
That's controversial. Many of them are actually toxic to the cells, and their effects on the metabolic activity and stem cell yield, it's all over the map.
So fresh fat is always the way to go if you can.
Generally, yes. Now that we've covered the basics of harvesting, processing, and injection, let's move on to some specific clinical techniques.
Sounds good. We've already talked about the Coleman technique. Are there any other techniques worth mentioning?
Oh, yeah. One that's pretty interesting is breast augmentation with external tissue expansion.
Tell me more about that.
So you combine fat grafting with a device like the Brava system. It's an external tissue expander worn for a few weeks before and after surgery.
How does that work?
It gently stretches the breast tissue, creating more space for the fat grafting. Then, the breasts are injected with lipoaspirate through multiple needle punctures, and you keep wearing the Brava for a few days after surgery to maintain that expansion.
What are the advantages of doing it that way?
Studies show you can graft a larger volume of fat, and the survival rates are better.
Makes sense. You're prepping the area, so to speak. Any other notable techniques?
Absolutely. Facial fat grafting, it's got its own set of considerations. It's a really powerful tool for rejuvenating the aging face and correcting craniofacial disorders. like hemifacial atrophy, for example.
What makes it so good for facial rejuvenation specifically?
A lot of facial volume loss is actually from the fat compartments depleting, so you're replenishing those, which creates a really natural look.
Makes sense. Are there particular techniques used for the face?
A lot of surgeons prefer the Coleman technique, the manual harvesting, to be as atraumatic as possible. And for purification, rolling the fat on that absorbent gauze we talked about is popular, again, to minimize trauma. And then injection is usually done with those small cannulas we discussed. Very precise, meticulous work.
So facial fat grafting, very delicate work.
Absolutely.
What about other areas, like the hands, for example?
Fat grafting is being used more and more for hand rejuvenation, especially for volume loss and making those tendons and veins less prominent.
Makes sense. And what about scars and contractures? Can fat grafting be used for those?
It can be helpful, yeah, especially for burns, radiation, or things like Dupuytren's contracture.
How does it help with those?
Seems like those stem cells in the fat graft are key here. They promote tissue regeneration and help improve the scar quality.
Interesting. So it's going beyond just filling space. It's almost like it's helping the body heal itself.
In a way, yeah.
We've talked a lot about aesthetic uses. What about reconstructive uses of fat grafting?
Huge potential there, particularly when you're dealing with irradiated tissue.
Why is that? What makes it so good for those cases?
Well, radiated tissue, it often has poor blood supply, lots of fibrosis, and just doesn't heal well. Fat grafting can help revitalize that tissue, make it more pliable, helps with wound healing.
So it's bringing life back to that damaged tissue.
Exactly. And again, those stem cells seem to play a big role. They can differentiate into different cell types. They stimulate new blood vessel growth. They even modulate the inflammatory response.
Wow, so it's really multifaceted.
It is. And this is especially important in radiation damage, where your other reconstructive options are pretty limited.
Makes sense. Now, before we get into complications, I want to touch on something fascinating. Fat grafting in regenerative medicine.
Ooh, yeah. Cutting edge stuff.
So adipose tissue, it's packed with these multipotent stromal cells, and those can differentiate into all sorts of cell types. Makes fat grafting really promising for new therapies, right?
Absolutely.
What are the main cell populations involved there?
You've got two main fractions. First is the stromal vascular fraction, SVF. It's a mixed bag of cells, including adipose stromal cells, hematopoietic stem cells, endothelial cells, fibroblasts, macrophages, parasites.
Okay, so lots of different cell types in that one.
Yeah. Then you've got the adipose tissue-derived stem cells, or ASCs. These guys are amazing. They can differentiate into fat cells, cartilage cells, bone cells, muscle cells, even heart muscle cells.
So you're saying potentially we could use fat to regenerate not just soft tissue, but cartilage, bone, muscle, even heart tissue.
Potentially, yeah. It's still early days, but research is ongoing.
What kind of things could these cell-based therapies be used for?
Oh man, all sorts. Involutional disorders, radiation damage, chronic wounds, inflammatory diseases, diabetes, neurological disorders, even cardiovascular disease. The possibilities are huge.
That's incredible. Are there clinical trials happening already?
Oh yeah, tons. Investigating the safety and efficacy for all sorts of applications.
What's the consensus right now on using this cell-enriched lipotransfer?
ASEPS and ASPS, they've issued a joint statement, acknowledge the potential, but caution that the evidence is still limited. More research is needed before this goes mainstream.
So a lot of potential, but proceed with caution for now.
Right.
All right, let's shift gears now and talk about complications. What are the most common ones we need to be aware of with fat grafting?
Fat resorption, that's the big one. Not all the fat survive, so some volume loss is expected.
How much is normal?
It depends. Patient's healing, the technique used, the area being treated, it's all over the map.
So how long does it take to see the final result then?
Usually about 6 months for the swelling to go down and everything to settle.
So patience is key. What if there's too much resorption? More than expected.
Well, if the patient isn't happy after 6 months, you can always do another round of grafting.
Okay, so multiple rounds might be necessary. What other complications can happen?
Aesthetic deformities could be at the recipient site or the donor site. Contour irregularities, lumps, dimpling, asymmetry.
How do you prevent those?
Meticulous technique again. Planning is crucial. Traumatic handling of the fat, even distribution during injection, and proper postoperative care.
Right, so it's about being careful and doing things right. Any other complications we need to be aware of?
Fat necrosis and calcification. That's when some of the fat dies and forms those hard lumps.
How common is that?
It can happen, but it's usually not a big deal. In the breast, it can sometimes create microcalcifications. Those can look like signs of cancer on a mammogram.
That sounds scary.
It can be, but those microcalcifications usually have a specific look. A good radiologist can tell the difference.
So good follow-up and communication are important.
Absolutely.
Anything else?
Pseudocysts, that's when a pocket of fluid forms.
What do you do about those?
You can often aspirate or drain them, but sometimes you need to surgically remove them.
Okay, so those can be tricky. Now, what about fat embolism? That's a rare one,
Yeah.
but potentially serious.
Right. Respiratory distress, neurological symptoms, petechial rash, those are the signs.
And how do you prevent it?
Meticulous technique during harvesting and injection. Don't use excessive pressure and be careful not to inject into blood vessels.
So it's about being gentle and precise.
Absolutely.
Any other rare but serious complications we should know about?
Lipoid meningitis. Super rare. Happens when you accidentally inject fat into the cerebrospinal fluid.
Oh, wow. How do you avoid that?
Know your anatomy. And again, precise injection technique.
So, fat grafting. Generally safe, but definitely carries some risks. All right, let's summarize. What are the key takeaways about fat grafting?
Patient counseling is huge. They need to know this is a technique-sensitive procedure. Results can be unpredictable. They might need multiple procedures.
And in terms of the technique itself?
Atraumatic technique, atraumatic technique, atraumatic technique, every step of the way.
Okay, we got that. Any specific tips for that?
Large bore cannula for harvesting, gentle negative pressure, avoid manhandling the fat during processing, and inject in small amounts, evenly distributed.
Got it. And after the surgery?
Compression garments. Prevents the graft from moving, helps prevent deformities and seromas.
So meticulous technique and proper post-op care. That's the recipe for success.
Exactly. And one last thing, fat grafting to the breast, it doesn't interfere with mammograms as long as you've got a good radiologist reading them.
That's good to know. Okay, let's do some practice questions now, see if you've been paying attention.
All right, hit me.
First question. Which of the following is not a component of a fat graft?
Think carefully about what's in that adipose tissue.
Option A, adipocytes.
Those are your mature fat cells, key part of the graft.
Option B, preadipocytes.
Those are the stem cells, important for survival and regeneration.
Option C, fibroblasts.
Fibroblasts make collagen, help with healing, but not a main part of the fat graft itself.
Option D, blood vessels.
Those are essential for survival, but they grow into the graft after it's transplanted, not there from the start.
So the answer is C, fibroblasts.
That's right.
Next question. Which donor site has the highest concentration of viable adipocytes?
Think about the different fat depots. Which one's got the best cells?
Option A, abdomen.
It's a common donor site, but not necessarily the best in terms of cell viability.
Option B, thighs.
Another common one, but again, not the top choice for cell quality.
Option C, buttocks.
Popular for its volume, but not necessarily bigger cells than elsewhere.
Option D. There's no significant difference between donor sites.
Ding, ding, ding. Studies show it doesn't matter that much where you harvest from.
So it's about practicality and aesthetics, not cell quality.
Ex-
All right, next question. Which fat processing technique is the least traumatic?
Think about how each technique works. Which one's the gentlest on those cells?
Option A, centrifugation.
That uses force, can damage cells.
Option B, washing.
Lots of mixing can disrupt cells.
Option C, sedimentation.
Just gravity, nice and gentle.
Option D, cotton gauze rolling.
That involves manual handling, but it's still pretty gentle.
So the best answer is C, sedimentation.
Correct. Cotton gauze rolling is gentle too, but sedimentation relies solely on gravity.
Okay, what's the ideal size for a fat graft aliquot to maximize cell survival?
Remember, those cells need nutrients. Think about what size allows for the best diffusion.
Option A, 0.1 cc.
That's a common injection volume, but not the ideal size for a single aliquot.
Option B, 1 cc.
Way too big. You'd get necrosis in the center.
Option C, 3 millimeters in diameter.
That's the sweet spot. Good nutrient diffusion minimizes necrosis.
Option D, 5 millimeters in diameter.
Too big. The cells in the middle wouldn't survive.
So 3 millimeters it is.
You got it.
Next, which of the following is not a potential complication of fat grafting?
Think about all the things that could go wrong.
Option A, infection.
Always a risk with surgery.
Option B, seroma formation.
Happens a lot, especially when you have dead space.
Option C, hyperpigmentation.
Can happen after any skin injury, but not specific to fat grafting.
Option D, fat necrosis.
That's when some of the fat dies, can cause lumps or calcification.
So the answer is C, Hyperpigmentation.
You got it.
Okay, last one. What does platelet-rich plasma do in fat grafting?
Think about what PRP is, what it's good for.
Option A, provides structural support.
It's more of a biological enhancer.
Option B, reduces the risk of infection.
It has some antimicrobial properties, but that's not its main role here.
Option C, enhances graft survival and blood vessel growth.
Bingo. Growth factors, all that good stuff. Stimulates healing, helps with those blood vessels.
Option D, dissolves excess fat.
Nope, it doesn't do that.
So the answer is C.
You nailed it.
All right, that's it for our practice questions. Hopefully you're starting to feel more comfortable with the key concepts.
Yeah, those are some high yield points for the exam, for sure.
Now, let's dive a bit deeper into some of the more nuanced aspects of fat grafting.
Let's do it.
First up, I want to talk about those zones of adherence we mentioned earlier. What exactly are they, and why do we need to be careful there?
So those zones, that's where the skin is really tightly bound to the underlying tissues. Less mobility, more prone to problems if you're too aggressive with the liposuction or fat grafting.
Okay, and where are these zones usually located?
The distal iliotibial tract, the gluteal crease, the lateral gluteal depression, middle medial thigh, distal posterior thigh.
So we need to be extra careful in those areas.
Yep. Avoid too much trauma. Keep the contour smooth.
What kind of problems can happen if you're not careful?
You can get dimpling, puckering, even skin tethering. Not a good look.
So it's about respecting the anatomy.
Exactly.
All right, let's shift gears and talk about fat grafting and breast reconstruction.
Big topic.
It's becoming increasingly popular.
Right.
What are the main advantages there?
It's a natural way to refine the shape, contour, and symmetry of the breasts. You can address volume deficits, smooth out irregularities, create a more natural cleavage.
What types of breast reconstruction is it good for?
All sorts. Implant-based, autologous, even after mastectomy without reconstruction.
So it's a versatile tool.
For sure.
Now, there's this technique, cell-assisted lipotransfer, or CAL. Can you tell me about that?
So with CAL, you're basically isolating and concentrating those stem cells, the stromal vascular fraction, SVF, from the fat. Then you add it back into the purified fat before injecting.
And why do you do that?
Those stem cells, they've got growth factors and all sorts of good stuff that helps with graft survival, blood vessel growth, and tissue regeneration.
So it's like a supercharged fat graft.
Exactly. And early studies suggest it might lead to better fat retention and better aesthetic outcomes.
Sounds promising. Any downsides to CL?
It's more complex, more expensive. You need special equipment and expertise to isolate that SVF.
Okay, so there are trade-offs. Now let's move on to facial rejuvenation.
Love this topic.
We talked about the basics earlier, but let's go deeper. What are the key areas of the face that benefit from fat grafting?
Pretty much any area where you've got volume loss or contour irregularities. Temples, cheeks, under eye area, nasolabial folds, marionette lines, lips, jawline.
So it's a comprehensive approach?
Absolutely. And you can tailor it to each patient's needs. That's the beauty of it.
Could you give me some specific examples?
Sure. Temples, you can restore volume, create a more youthful, rounded contour. Cheeks, you can lift the midface, create that heart-shaped look. Under eye area, you can reduce hollowness and improve those dark circles.
In the lower face?
Nasolabial folds, marionette lines, you can soften them. Lips, you can enhance volume and definition. Jawline, you can create a more defined, sculpted look.
So fat grafting can address a wide range of those age-related changes.
Exactly.
Now, what about this microfat grafting I've been hearing about?
Microfat grafting. It's all about using even smaller cannulas and injecting teeny tiny aliquots of fat. Creates a super refined result, especially in delicate areas like under the eyes or lips.
Makes sense. Less is more in those areas.
Exactly. And since you're injecting such small amounts, the risk of lumps or irregularities is much lower.
Okay, let's move on to hand rejuvenation. Another area where fat grafting is gaining popularity.
Yeah, it's really interesting.
How does fat grafting help with aging hands specifically?
Well, as we age, our hands lose volume. The tendons, veins, bones, they all become more prominent. So fat grafting can restore that volume, plump up the skin, makes the hands look younger.
Which parts of the hands can be treated?
You can augment the back of the hands, fill in those hollows between the tendons, and even improve the look of those prominent veins.
It's pretty versatile.
It is. And the results can be really impressive. You can take years off someone's hands.
Now let's talk about something that's often overlooked, the psychological impact of fat grafting.
Yeah, it's an important aspect.
How does fat grafting affect patients psychologically?
It can be really positive for their self-esteem and body image. When you address those areas that bother them, restore a more youthful look, It can really boost their confidence.
That makes sense. Feeling good about yourself is a big part of overall well-being.
Absolutely. It's a reminder that we need to take a holistic approach. Consider the emotional side of things, too.
All right. Let's talk about the future of fat grafting. What exciting developments are on the horizon?
Oh, there's so much happening. One area that's really exciting is the development of cell-based therapies using those adipose-derived stem cells.
So we're talking about using fat not just for aesthetics, but for actual therapy.
Exactly. And research is going full steam ahead to figure out how to make those therapies safe and effective.
What other advancements are we seeing?
There's a lot of work being done on biomaterials and scaffolds. You can combine those with fat grafts to help them survive and integrate better.
How do those work?
They provide a framework for the fat to attach to. And they can release growth factors and other things to stimulate tissue regeneration.
So it's like creating the perfect environment for those fat cells to thrive.
That's the idea.
Now let's talk about burn scars, a really challenging area.
Absolutely.
How can fat grafting help with those?
It can make a huge difference in the appearance and function of burn scars. It can soften and smooth the scar tissue, restore volume, improve the elasticity of the skin.
What's the mechanism there? How does it work?
Those stem cells are added again. They can turn into fibroblasts, which produce collagen and elastin, and those help remodel the scar tissue.
So it's not just covering up the scar, it's actually helping the tissue regenerate.
Right, and that can lead to big improvements in both how the scar looks and how well the area functions.
What types of burn scars are good candidates for fat grafting?
It can be used for hypertrophic scars, contractures, areas where there's volume loss, lots of different types.
When's the best time to do it? After the injury?
It depends on the burn, how severe it was, the patient's overall health. But usually you want to wait until the wound has healed completely and the scar tissue has stabilized.
Okay, now let's talk about radiation damage. Another tough one.
Yeah, it can be really challenging to treat.
Radiation therapy is life-saving, but it can really damage the surrounding tissues. How does fat grafting help in those cases?
Radiation often causes fibrosis, poor blood supply, bad healing. Fat grafting can help revitalize those tissues, makes them more pliable, improves healing.
What are the specific benefits?
It can soften and smooth that fibrotic tissue, reduce pain and discomfort, improve mobility. It can even help hair grow back.
That's amazing. So many potential benefits.
Yeah, it can really improve quality of life for these patients.
Now let's talk about craniofacial microsomia, a very complex condition.
A challenging one for sure.
How can fat grafting help those patients?
It can be used to restore volume and symmetry to the affected areas of the face. Improves both the aesthetics and the function.
Which areas can be treated?
Cheeks, jaw, chin, lips, even the area around the eyes.
So it can address a wide range of deformities.
Exactly. And for these patients, the results can be life-changing. Improve their self-esteem, their quality of life.
Now, let's talk about something that's been getting a lot of attention lately. Hair restoration with fat grafting.
Yeah, it's a hot topic.
Can fat grafting really make hair grow?
There's more and more evidence suggesting that it can, especially for androgenetic alopecia, the most common type of hair loss.
How does it work?
Seems like those stem cells in the fat graft interact with the hair follicles, stimulating them and making new hair grow.
So it's not about transplanting hair, it's about making the scalp healthier.
Exactly. And this could really change the way we approach hair loss. It's a natural, minimally invasive option.
Now let's talk about gender-affirming surgery.
An important and growing area.
Fat grafting is playing a big role in these procedures. How is it used?
It's used to enhance and contour different body parts to align with the patient's gender identity.
Can you give some examples?
In transgender women, it's often used for breast augmentation, to create more feminine curves in the hips and buttocks, and to soften the facial features. In transgender men, it can be used to augment the chest, create a more masculine jawline, and enhance the genitalia.
So it's very individualized, tailored to each patient's goals.
Exactly. And the results can be incredibly empowering for these patients. Helps them feel more comfortable and confident in their own bodies.
Now let's shift gears and talk about patient selection. We've covered all these amazing applications, but not everyone is a good candidate for fat grafting, right?
Right.
What are the most important factors to consider when evaluating a patient?
Their overall health, their medical history. Some conditions like diabetes, autoimmune disorders, bleeding disorders can increase the risks.
What else is important?
Their skin quality, how much donor fat they have, their expectations, and their willingness to commit to the recovery process.
So it's a pretty thorough evaluation.
It has to be. And You have to be really honest with the patient. Make sure their expectations are realistic, that they understand the risks and benefits.
Good communication is key. Now, let's talk about meticulous technique. We've touched on it throughout the discussion, but I want to emphasize it again. Why is it so crucial?
Fat grafting, it's delicate. Even small changes in technique can make a big difference in the outcome.
How so?
Every step matters. Harvesting, processing, injecting, you have to do it carefully, precisely to minimize trauma to those fat cells and make sure they survive.
What are some common mistakes? Things to avoid.
Too much pressure during harvesting, over-manipulating the fat, injecting too much in one spot, not distributing it evenly. All those things can lead to problems.
So finesse and attention to detail are key.
Absolutely. And you always have to keep learning, keep refining your technique.
Now let's talk about technology. How has technology impacted the way we do fat grafting?
Oh, it's changing everything. Better harvesting techniques, better processing, ways to improve graft survival, ways to monitor the results. It's really amazing.
Can you give me some examples?
Sure, power-assisted liposuction, water-assisted liposuction. Those are newer techniques that allow for more precise and gentle fat harvesting. Less damage to the cells, better quality tissue.
And for processing?
There are closed systems now that are much more sophisticated. They separate the fat more efficiently, and they're more sterile.
What about for improving graft survival?
There are techniques to enrich the grafts with growth factors,
Ah.
and we're using imaging like ultrasound and MRI to monitor how well the graft is integrating and to assess the long-term results.
So technology is helping us refine every step of the process.
Exactly. And we're just getting started. I think we'll see even more incredible advancements in the next few years.
Now let's talk about some ethical considerations.
Always important to consider.
Fat grafting is a powerful tool, but it raises some ethical questions. What are some of the key issues?
One big one is the potential for overuse or misuse, especially in aesthetics. We have to make sure patients understand the risks and benefits and that their expectations are realistic.
Right. It's not a magic solution for everything.
Exactly. And it's not a substitute for a healthy lifestyle.
What other ethical considerations are there?
The way fat grafting is marketed and promoted, we can't exaggerate claims or promise unrealistic results. Transparency and honesty are crucial.
So responsible advertising and patient education are key.
Absolutely. And we also have to be aware of the social pressures and body image concerns that might be driving patients to seek fat grafting.
So addressing those underlying psychological factors is important too.
Definitely.
Now, let's take a step back and look at the big picture. Fat grafting has come a long way, hasn't it?
It has. It's incredible, really.
What are some of the key milestones in its evolution?
Well, the idea of using fat for grafting goes back to the late 1800s, but it wasn't until the mid to late 1900s that it started to gain traction.
What were the challenges in those early days?
The results were often unpredictable, and there were a lot of complications. We didn't really understand the biology of fat transplantation.
So it was a lot of trial and error.
Yeah, pretty much. But then you had pioneers like Sidney Coleman and Roger Amar who really dedicated themselves to figuring it out. They standardized the techniques, made them safer and more effective.
What were the biggest contributions?
Coleman emphasized atraumatic harvesting and meticulous injection technique, and Amar introduced the concept of structural fat grafting.
And those advancements laid the foundation for what we do today.
Exactly. And since then, the research and innovation have exploded. Better techniques, better outcomes, more applications.
It's really remarkable.
It is. From a fringe procedure to a mainstream technique, it's pretty amazing.
Now, as we wrap up, I want to touch on some of the unanswered questions. What are we still trying to figure out about fat grafting?
Oh, there's still so much we don't know. One of the biggest mysteries is exactly how those fat grafts survive and integrate into the surrounding tissue.
So we know it involves blood vessel growth and stem cells, but we don't know all the details.
Right, and if we can figure out those details, we can develop even better ways to improve graft survival and get even better results.
What else are we working on?
We need better ways to measure and predict fat graft survival. Right now, it's mostly subjective. We need more objective tools.
That would be a game changer.
It would. More standardized treatments, more consistent results.
Any other frontiers?
Regenerative medicine. Using fat for things beyond aesthetics. That's where the real magic is going to happen.
It's an exciting time to be in this field. So much potential.
It really is.
Well, that brings us to the end of our deep dive into fat grafting. We've covered a lot of ground today. Hopefully you've gained a deeper understanding of this incredible procedure.
I hope so.
Remember, mastering the principles of fat grafting is crucial for getting good results. Patient selection, meticulous technique, it all matters.
Absolutely. And as you continue your studies, remember that this field is always changing. Stay curious, stay up to date, and always strive to improve your skills.
And always put the patient first. Safety, ethics, evidence-based practice.
Couldn't have said it better myself.
Good luck on your FRCS BLAS exam. We're rooting for you.
And best of luck in your careers.
Thanks for joining us on the deep dive. Until next time, keep learning.